So I'm going to go ahead and get us started. Welcome, everyone. My name is Elena Kidd, and I'm a program director with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. I'm very excited to welcome you to today's webinar, Understanding Multi-Drug-Resistant Organisms, featuring Kate Draper, a Council of State and Territorial Epidemiologist, Applied Epidemiology Fellow with the Infectious Diseases and Outbreaks Division at the Alabama Department of Public Health. This is the first part of a 6-part webinar series that will focus on MDRO, so please be on the lookout for more information about our remaining webinars. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control, Training and Technical Assistance, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past webinars and podcasts, sign up for our newsletter, request training and technical assistance, or view infection prevention and control resources at uab.edu/ARC-IPC. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety, the Alabama Public Health Training Network at the Alabama Department of Public Health, and the Alabama Statewide Area Health Education Centers. You can learn more about their programs and the centers as a whole on the websites listed on this screen. We'd also like to let you know about our next upcoming webinar. Again, this will be the second of our MDRO webinar series. Yes, having a robust hand hygiene program is still important with Mary Duncan. Hand hygiene has been the cornerstone of a strong infection prevention program for years. However, creating a robust hand hygiene program is not as simple as it sounds. This presentation will explain why every healthcare facility needs a hand hygiene program and identify the key elements that are needed. We'll review what should be included in the audit, who should perform the audits, how to educate the auditors, and what you can do with the results of the audits. We'll explore some auditing tools and resources available. Finally, we'll discuss some innovative ways to engage staff in the hand hygiene program. This webinar is presented by the Alabama Regional Center for Infection Prevention and Control and co-sponsored by the Deep South Center for Occupational Health and Safety and the Alabama Statewide Area Health Education Centers. And it will be held March 12th at 12 p.m. Central Standard Time. And a link to register is on the slide and will also be sent to you in a follow-up email. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must register for the training, watch the entire program, complete the evaluation following the program, and upon completing that evaluation, you'll be redirected to the Alabama Nursing CEU request form, which you will also need to complete. CEUs for nurses watching this program live will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit directly to Alabama Board of Nursing. CEs for this program will expire February 7th, 2025. A certificate of participation can also be provided by following the steps listed above for anyone who will need their certificate for requesting CEs outside the state of Alabama. If you experience any technical issues or any issues in the CE application, please email arcipc@uab.edu. We will place this email in the chat box as well. And finally, it is my pleasure to introduce our speaker. Kate Draper is currently a Council of State and Territorial Epidemiologist, Applied Epidemiology Fellow with the Infectious Diseases and Outbreaks Division at the Alabama Department of Public Health. She received a Bachelor's of Science in Molecular Microbiology and Immunology in 2019 and a Master's in Public Health with a concentration in Epidemiology in 2022 from the University of Nevada at Reno. In her current position, she assists with outbreak activities related to foodborne diseases and healthcare-acquired infections, as well as pursues projects related to health equity and HAI, and shadows other ADPH departments for a holistic understanding of public health. So we are very excited today to have Ms. Kate Draper. So I will turn things over to you.
All right. Hello, my name is Kate Draper. As Elena mentioned, I'm a CST fellow working in the Healthcare Associated Infections and Antimicrobial Resistance Program within the Infectious Diseases and Outbreaks Division at the Alabama Department of Public Health. Today, I'm going to provide an overview of multi-drug resistant organisms, which I will be referring to as MDROs throughout the presentation. These organisms pose a significant global health threat, and the aim of our discussion will be to focus on their impact, causes, and potential solutions. Our objective today is quite simple. First, we will take some time to discuss the emergence of MDROs and how we can help to prevent their spread. My hope is that the information presented today will lay a foundation of knowledge that can be built upon in the future. So let's start with the basics. What are MDROs? This term typically refers to bacteria or fungi that are resistant to at least one or more classes of antimicrobials. MDROs can be very difficult to treat and therefore can cause serious illness or even death. The term MDRO is an umbrella term that covers many different types of germs. The ones that we will be focused on today are often described as emerging MDROs. These include Candida auris, carbapenem-resistant enterobacterales, or CRE, carbapenem-resistant Acinetobacter baumannii, or CRAB, and carbapenem-resistant Pseudomonas aeruginosa, or CRPA. So, where do MDRs come from? To make a very complex story simple, germs are exposed to antimicrobials that are out to destroy them all the time in people, animals, and our environment. To defend themselves, they develop or acquire ways to resist these antimicrobials. Some of this resistance can be spread from the pathogen to their progeny, as depicted on the slide. But sometimes the resistance is shared by jumping between different germ types. On the left, we have a resistant E. coli pathogen that is exchanging its genetic material with a once susceptible Klebsiella pneumoniae bacteria. This is known as horizontal gene transfer and turns otherwise harmless bacteria into drug resistant superbugs. So let's take a deeper dive and talk a little bit more about bacterial resistance mechanisms. We'll start with carbapenemase producing organisms, or CPOs, shown in the smaller green circle. These bacteria are a subset of organisms that produce enzymes that make them resistant to carbapenem antibiotics. These enzymes are known as carbapenemases and are typically associated with Acinetobacter baumannii, Pseudomonas aeruginosa, and bacteria in the Enterobacterales order, such as E. coli, Citrobacter, Enterobacter, and Klebsiella species. CROs, or carbapenem-resistant organisms, is the larger blue circle and is any organism that is resistant to carbapenem antibiotics, regardless of having a carbapenemase or not. When looking at the different types of organisms listed on the slide, you will notice that the conventional naming is quite similar between groups. The only difference is when referencing carbapenemase-producing organisms, the letters CP are placed at the beginning. So, for example, CP crab stands for carbapenemase producing carbapenem resistant Acinetobacter baumannii, and so on and so forth. Not only do carbapenemases destroy carbapenem antibiotics, but they also inactivate other antibiotics from the same beta-lactam antibiotic class, such as penicillin and cephalosporins. Finally, and most importantly, they can also harbor resistance to other important classes of antibiotics, leaving little or no antibiotics to treat them at all. So, which carbapenemases do we need to keep an eye out for? The carbapenemases listed on the slide are known as the Big Five and are the main carbapenemases currently causing clinical problems in the United States. These include Klebsiella pneumoniae carbapenemase, or KPC, New Delhi metallobeta-lactamase, abbreviated NDM, Verona integron encoded metallobeta-lactamase, or VIM, imipenemase metallobeta-lactamase, or IMP, and finally oxycylinase 48 like beta-lactamase, or OXA48. To put this into perspective, KPC CRE was first identified in 2001 from two states, and since then, KPC CRE has spread from these two states to all 50 states, DC, and Puerto Rico in just 17 years. And now we're also starting to see a concerning rise of other carbapenemases besides KPC. Hopefully, this paints a clear picture as to why we're concerned about these bacteria. They are highly drug resistant and can spread rapidly throughout our environment, causing serious outbreaks and dramatically limiting treatment options for those affected. So, who is at highest risk for acquiring these infections? MDROs tend to affect the most vulnerable people, like the ones who require multiple and often prolonged healthcare stays, or those that have invasive devices, are ventilator dependent, were admitted to the ICU, or recently received broad spectrum antibiotics or antifungals. These individuals need to be carefully managed to prevent MDRO acquisition. So, in addition to the emerging MDROs among bacteria we have discussed, there is also an emerging multi-drug resistant yeast that represents significant global health threat. This yeast is known as Candida auris and is very different from other Candida species. It's known to be resistant to all three types of antifungal medications, making it, you guessed it, highly drug resistant. It can colonize the skin and lead to invasive infections and even death for those with serious medical conditions. Unfortunately, the mortality rate is greater than 45% in the first 30 days. As alluded to earlier, it's also becoming more common worldwide. C. auris was identified in 2009 and has spread quickly, causing infections in more than a dozen countries. What's especially challenging is that it's often difficult to identify. Unless specialized laboratory technology is used, C. auris can be misidentified as other types of fungi, which may lead to initiating the wrong treatment and delaying appropriate infection control strategies. Finally, C. auris can spread very easily in healthcare facilities via contaminated surfaces or equipment or through contact with infected or colonized individuals. Good hand hygiene and environmental cleaning in these settings is crucial to prevent outbreaks and further spread. So let's talk about MDRO colonization. Some people may not have any signs or symptoms of infection, but can still have an MDRO living on or inside of them. This is called being colonized. Some colonized people will go on to develop an infection, but as you can see with the iceberg image, there are many more people colonized than infected. In other words, the infected people we do see are just the tip of the iceberg, while the number of colonized people among us is much higher and can't easily be seen. This is an important concept because colonized people can pass the MDRO they're carrying to other people or their environment, and unlike people who are infected, we may not be applying the same infection control actions, such as the use of gowns and gloves during their care. We often get the question, how long can someone be colonized? Unfortunately, there is not a one size fits all answer. Colonization can last for a very long time. Surveillance data shows that patients can remain colonized for several months, and it's likely that it may persist even longer, particularly with Candida auris. Residents have been shown to remain colonized for longer than 2 years. While some people may eventually become decolonized, they may just as easily become recolonized again. In a recent study among patients who had an initial positive MDRO screening result, followed by one or more negative screening results, more than 50% of those cases had a subsequent positive screening result. It is for these reasons that we don't tend to recommend retesting someone for colonization status once you know they are already colonized. And regarding decolonization, despite being an area of great interest, there are currently no well-established decolonization strategies for the MDROs we're discussing today. So next, let's look at the factors contributing to multi-drug-resistant organisms and their spread. As you can see from some of the images on the slide, this includes the overuse and misuse of antibiotics in people and animals, the lack of new antibiotics being developed, and poor infection control practices in healthcare settings. We'll discuss each category in more detail over the next few slides. One significant factor that contributes to the development of MDROs is the overuse and misuse of antibiotics. This leads to the destruction of the body's protective, non-resistant bacteria and helps to create drug-resistant bacteria. If we follow the image here on the slide, we see that the resistant bacteria has survived the antibiotic treatment and now has the perfect environment to grow, amplify, and take over. As we discussed earlier, this makes it very easy to share resistance with other bacteria. While antibiotics are certainly one of the greatest advances in medicine, judicious use of these drugs must remain in place to assure retention of antibiotic susceptibility for years to come. One of the major reasons for the MDRO crisis is the stalling of antibiotic development over the past 34 years. Scientists call this the antibiotic discovery void. Researchers discovered the last class of highly effective antibiotics in 1987. Since then, no new antibiotics have made it out of the lab. This is partly because there was no financial incentive for the pharmaceutical industry to invest in further research and development, but also antibiotics at the time were effective at what they did. Unlike chronic diseases like hypertension and diabetes, bacterial infections don't typically require ongoing treatment and so have a lower return on investment. Reversing this trend requires investment not just in drug development, but also in the basic research that allows scientists to understand how antibiotics and bacteria work in the first place. However, reversing the trend and lack of research has thankfully come sooner rather than later. New research out of MIT and Harvard has tapped into AI to discover a new class of antibiotic candidates. 283 promising new compounds were identified. They've begun testing on mice, but there's still further testing that needs to be done before the detected compounds can be translated into clinical drugs. Another factor contributing to MDRO spread is poor infection control programs, lack of resources. Lack of resources tends to be one of the major limitations in achieving optimal infection control programs. Specifically, healthcare facilities must routinely address challenges around staffing, access to medical supplies and equipment, as well as maintaining robust infection prevention processes and systems. Additionally, surveillance and reporting requirements can be very time consuming. It's been estimated that an unsustainable proportion of surveillance activities continue to be performed manually as opposed to leveraging some of automated system. Manual surveillance activities demand more time and are prone to errors which negatively impact process improvement and IPC program effectiveness. Most importantly, manual surveillance processes leave IPs with less time for other patient safety efforts that may be equally, if not more important. Overall, IPC programs are faced with navigating a constantly changing healthcare landscape while also needing to maintain reliable evidence-based approaches at the same time. While this slide focuses on healthcare facilities, it's critical that advances are also made to improve IPC efforts across the larger continuum of care as well as within national and global public health sectors. So, speaking of global IPC efforts, we know that globalization can fuel the spread of antimicrobial resistance through increased travel and trade. In some countries, including parts of Europe, Asia, Africa, and South America, antibiotics are commonly bought without a prescription. This unregulated and overuse of antibiotics further supports drug resistance worldwide, and MDROs commonly associated with other countries are now causing infections in the US. For example, the NDM carbapenemase, which was historically only associated with international travel to India and Pakistan, began presenting in local US cases with no travel history in June 2010. Additionally, new research shows that the global trade in antibiotics for use on livestock farms is still driving the spread of MDROs in low and middle income countries. So let's talk a little bit more about antibiotic use among livestock. This is another top contributor to the spread of MDROs. An estimated 73% of all medically important antibiotics sold worldwide are for livestock production rather than for people, largely for growth promotion in healthy animals. Antibiotics are given at low doses, inadvertently supporting the development of antibiotic resistance. Additionally, overcrowding and unsanitary conditions in modern factory farms create the ideal breeding ground for antibiotic resistant or AR infections. This resistance can then pass to humans through the animal's meat or from products grown in the soil fertilized with the animal's manure. Next, we will discuss the impact of MDROs. According to the CDC, more than 2.8 million MDRO infections occur each year, with more than 35,000 people dying as a result. When Clostridioides difficile, or C. diff, a bacterium that can cause deadly diarrhea and is associated with antibiotic use, is included with these numbers, the estimate rises to 3 million infections and 48,000 deaths. Generally, MDRO infections negatively impact the length of a patient's stay in a hospital. According to one study, the average increased length of stay due to MDRO infections was 14 days. However, infections caused by CRPA can increase a patient's hospital stay up to 27 days. Longer hospital stays are one of the main contributors associated with increased healthcare cost. Other contributing factors include longer duration of illness, additional diagnostic tests, and prolonged antimicrobial therapy. The estimated national cost to treat MDRO infections is $4.6 billion annually. As we've discussed, MDRO infections leave us with very little treatment options. This abbreviated timeline of antibiotic resistance shows when the antibiotic was introduced on the top and the coordinating appearance of resistance on the bottom. According to the World Health Organization, or WHO, the pace of development for new antibiotic treatments has been inadequate to address the growing threat of antibiotic resistance. In 2021, there were only 27 new antibiotics in clinical development against priority pathogens, down from 31 products in 2017. On average, resistance is reported to most new agents 2 to 3 years post-market entry. This undermines the effectiveness of the limited number of new antibiotics that reach the market. Next, let's take a look at some of the most common infections caused by MDROs. First, urinary tract infections, or UTIs, are the most common type of healthcare-associated infection reported. Gram-negative bacilli, including E. coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, and Enterobacter species, are responsible for about 80% of all UTI cases, and approximately 75% of UTIs are associated with a urinary catheter. These numbers indicate a potential gap in prevention education and highlight the importance of evidence-based prevention measures, such as catheter-associated UTI or CAUTI prevention bundles. Evidence-based interventions can be used individually, but are most often bundled together for best practices with the objective of enhancing patient outcomes. A CAUTI bundle is designed for healthcare settings and typically includes guidelines for appropriate catheter use, proper insertion and maintenance interventions, and prompt removal interventions. Hospital-acquired pneumonia, or HAP, caused by Klebsiella pneumoniae, Acinetobacter, Pseudomonas, and E. coli, is the second most common HAI and the leading cause of death worldwide, affecting 0.5 to 1.7% of hospitalized patients. In the ICU, ventilator-associated pneumonia, also abbreviated as VAP, accounts for 25% of all infections. VAP patients experience a higher prevalence of multidrug-resistant, or MDR, Pseudomonas and Acinetobacter strains, ranging from 76.13 to 95.3%. The most common causes of HAP include aspiration or bacterial spread from the urinary and gastrointestinal tract through the bloodstream. The VAP prevention bundle recommends elevation of the head of the bed between 30 and 45 degrees, daily lightening of sedation to assess the patient's readiness to extubate, use of subglottic secretion drainage tubes, and oral care for every 4 hours to prevent increased risk of VAP. Surgical site infections, or SSIs, are post-operative infections occurring within 30 days of surgery. Surgical site infections can be superficial, those involving only the skin or subcutaneous tissue, deep incisional infections, those involving deep, soft tissues of an incision, or infections involving organs or body spaces. Organ and space SSIs are associated with higher mortality rates than superficial SSIs. According to the CDC, SSIs account for 20% of all HAIs and is associated with a 2 to 11-fold increase in the risk of mortality, with 75% of SSI-associated deaths being directly attributable to the SSI. E. coli and Staphylococcus aureus are the predominant pathogens responsible for these infections. In one study, antibiotic use, chronic renal failure, and diabetes in patients who underwent emergency surgery were more likely to acquire MDR SSIs. To improve patient safety during surgery, some recommended interventions for bundling include bathing or showering the patient with an antiseptic or antibacterial soap the night before the procedure. Antibiotic prophylaxis should be administered and timed so that the agent is established in the blood and tissues prior to surgery. Skin should be prepped with an alcohol-based agent, and a normal body temperature should be maintained throughout the process. The last common infection caused by MDROs that we'll talk about today are bloodstream infections, or BSIs. An estimated 250,000 BSIs occur annually. Most are related to the presence of central venous catheters, which are the primary source of hospital-acquired bloodstream infections. Other indwelling devices known to be associated with BSIs include urinary catheters and mechanical ventilators. Additional risk factors for acquiring MDR BSIs include previous antimicrobial use, liver disease, and bacteremia caused by Klebsiella pneumoniae. Prevention bundles for central line associated bloodstream infections, or CLABCs, include proper education on catheter insertion, care, and maintenance for healthcare personnel, performing hand hygiene prior to catheter insertion or manipulation, ensuring appropriate nurse-to-patient ratio, and performing surveillance for CLABCs in ICU and non-ICU settings. As we saw earlier in the presentation, the infections just discussed can result in thousands of deaths and billions of dollars in healthcare costs. But the good news is they are all preventable. Next, we'll look at common methods of MDR diagnosis and detection. First, let's discuss how the clinical laboratory uses validated microbiological tests to detect and prevent the spread of MDROs. Some examples of these tests include organism identification, antibiotic susceptibility testing, phenotypic and genotypic carbapenemase testing. Depending on facility type, organism identification and antibiotic susceptibility testing are commonly performed in-house, and phenotypic and genotypic carbapenemase testing are performed externally. Organism identification refers to laboratory tests used to distinguish organisms from each other. The preferred testing method for species identification is MALDI-TOF, which is a routine diagnostic process for infectious diseases in current clinical settings. The rapid, low-cost, and simple-to-conduct methodology is expanding its application in clinical microbiology laboratories to diagnose the antimicrobial resistance, or AMR, in microorganisms. The next step is antibiotic susceptibility testing, or AST, which determines which antibiotics would be most effective at treating the patient and killing the organism. The AST results show if a bacteria are susceptible, meaning the bacteria can be treated with the drug, intermediate, meaning bacteria may be treatable with the drug but may require adjusted dosage, or resistant, meaning bacteria cannot be treated with the drug. The phenotypic carbapenemase test is used to identify if a bacteria produces a carbapenemase. As I mentioned earlier, carbapenemases are particularly problematic because they can share resistance mechanisms with other bacteria, leading to rapid spread of drug resistance among multiple classes of organisms. MSIM and CarbaNP are two diagnostic tests that identify the physical presence of a carbapenemase. For example, CarbaNP is a rapid diagnostic test that confirms the presence of a carbapenemase, providing reliable results in as little as 30 minutes and up to 2 hours, which allows clinicians to quickly implement the appropriate control measures. Finally, genetic testing is performed. This testing, done by PCR or whole genome sequencing, is used to determine the specific carbapenemase producing gene that is present, such as CasePC or NDM. As previously mentioned, the first two parts of the recommended testing algorithm, organism identification and AST, can typically be performed in-house. The last two parts of the testing algorithm, phenotypic and genotypic testing, are usually required to be sent out to a reference laboratory. In the near future, the state public health laboratory will be able to perform this testing at no cost to you. Clinical laboratory recruitment and outreach will be an ongoing activity once this testing has been initiated. Specimens submitted to the state lab may be forwarded to the CDC's Antibiotic Resistance Laboratory Network, abbreviated ARLN, which was established in 2016 and provides nationwide lab capacity to rapidly detect antimicrobial resistance and inform local responses to prevent spread and protect people. It closes the gap between local capabilities and the data needed to combat antimicrobial resistance in the US. As a whole, the network tracks changes in resistance and helps disease detectives identify and respond to outbreaks faster. Next, we'll look at screening methods used to identify people who may be colonized with an MDRO. There are several ways to accomplish this, including point prevalence surveys, or PPSs, admission screening, and discharge screening, all of which are considered types of colonization screenings. The topic of colonization screening can be quite complex, but for all of these methods, facilities collect a swab at different body sites, such as the axilla and groin for Candida auris, and rectal swabs for most CPOs, which is then sent to a laboratory to see if they can identify the MDRO of interest. If they do, then the person is considered colonized. First, let's look at PPSs. A point prevalence survey is a form of colonization screening conducted at a single point in time on a number of people within a facility to see if they are colonized. Despite the use of the term survey, this is not research or the result of some regulatory action, but is an important type of public health surveillance. There are two types of PPSs. The first is a response-based PPS conducted in response to the identification of someone with an MDRO with the goal of identifying additional individuals within a facility for whom IPC actions are required. In addition, it can also suggest whether transmission is occurring within the facility. Response PPSs can be utilized at all facilities, although whether or not they are used can depend upon several factors such as how robust a facility's infection control program is, how many people with the MDRO are currently in the facility, or how common the MDRO is within the state. So let's talk about who should be screened. Sometimes you can start by initially screening a select or targeted group of people, such as those at highest risk for MDRO colonization on a unit, to include roommates or those that may have shared bathrooms. However, transmission often occurs well beyond roommates, so it should also include other people at high risk, like those who are ventilated or bedbound. Oftentimes, broader screening, such as an entire unit or even a facility, is needed and more appropriate. Things to consider for broad-based screening are if there are many individuals at high risk for MDROs on a unit, or if determining who is at high risk is just too time-consuming and will delay the PPS, or if the initial targeted screening reveals more people with the MDRO. Per CDC MDRO response guidance, which was updated in November 2022, broad-based screening is the preferred method after the identification of a single case. So besides response PPSs, the other type of PPS is something called a proactive type. And these are PPSs conducted at a facility regardless and sometimes even prior to the identification of someone with an MDRO. And they can be particularly helpful in facilities that are at highest risk for the transmission of these MDROs. These proactive PPSs are used instead of waiting for a signal and in turn taking a more proactive approach to finding colonized individuals. This will allow for better detection and intervention, bringing benefit both to the facility and for the greater healthcare system. And if utilized early enough, it may allow you to catch an issue when it's just a small flame, as compared to a wildfire where control can be much more difficult. These proactive PPSs can occur as needed, or they could be considered part of your regularly scheduled infection control practices, such as every 4 to 6 months, especially for ventilator-associated skilled nursing facilities, or VSNFs, and long-term acute care hospitals, or LTACs, who will continuously face threats from MDROs. Additionally, it does benefit the facility to look for more than one type of MDRO during these PPSs, for example, screening for both auris and CPOs. Let's move on to another type of colonization screening, which attempts to detect the MDRO upon someone's admission to a unit or facility. This is known as admission screening. And while any facility can utilize admission screenings, there may be a benefit to certain facility types under certain circumstances. For example, VSNFs and LTACs. Admission screening is best initiated along with regularly scheduled proactive PPSs because a facility with only a few people with the MDRO will benefit the most from admission screening. There's one exception to this, which is a facility that has very good infection control practices, but there are many people with MDROs. This is especially true if you have a dedicated unit to care for people with MDROs, as the admission screening would help you better ensure resident placement. Admission screenings will also greatly benefit those who frequently share residence with LTACs and VSNFs. In order to implement admission screening well, it will require you to develop a plan that makes sense for your facility. Two of the biggest factors to consider when developing your plan include who you will screen upon admission and how you will identify them. The two questions really boil down to available laboratory resources and how you can best maximize the odds of identification with the benefits of that identification among those you screen. To highlight this idea, I've given several examples of how some facilities have chosen to use admission screening on this slide. A VSNF can choose to screen all admissions to their ventilator unit, while an LTAC will screen all admissions regardless of where they are placed in the facility. For skilled nursing facilities, or SNFs, and other healthcare facilities, they may choose to screen all admissions from high-risk facilities such as LTACs or BSNFs. They can also choose to only screen admissions with MDRO risk factors from these facility types. Another approach would be to screen residents admitted to the facility after an overnight stay in a healthcare facility outside the U.S. in the prior 6 months. The last type of colonization screening we will talk about today is discharge screening. This type of screening is especially useful when a unit or entire facility is experiencing an outbreak, or if your facility in general just cares for many people with MDROs, even if you're not in a current outbreak. The successful implementation of discharge screening requires a well-developed implementation plan. For instance, can your lab perform it, or if not, are there other public health resources, and how long will it take to get a result? You will also need to decide when to actually screen. Predicting these times can be challenging and sometimes completely unplanned. It may be best to screen as part of the discharge process. For planned discharges, you could try to screen a day or two prior to discharge in order to have the result prior to transfer. In addition, you will need to consider who you will screen. As an example, you could focus screening for those discharging from an outbreak unit or facility to places at highest risk for MDR transmission. Communication is key to be sure to communicate results with health department and the accepting facility or unit. If the discharge results are not back by the time of discharge, the accepting facility or unit should be made aware of these pending results. If the transfer unit is experiencing an outbreak, then ideally the accepting unit or facility will use the recommended infection control practices, such as the use of enhanced barrier precautions, until the testing results are available. And once the results are available, it should be communicated back to the accepting facility or unit. Every pending discharge screening result should not delay someone's transfer once they're medically ready for transfer, nor should they prevent someone's acceptance to another facility or unit. Next, we're going to talk a little bit about surveillance. Some of you on the call may be familiar with the CDC's National Healthcare Safety Network, or NHSN, the nation's most widely used healthcare-associated infection tracking system. NHSN contains an antimicrobial use and resistance surveillance module, also known as the AUR module, that provides a way for facilities to establish baseline measures, guide goal setting, and measure progress. Currently, only hospitals are eligible to report to the AUR module. However, other healthcare facility types can use internal tracking tools to measure similar metrics. An Excel-based tracking tool can be used to capture information on the resident's location, classification of infection, health history, laboratory diagnostics, prescription antibiotics, among other information. Monthly data can then be automatically summarized and populated into tables and graphs, creating a data visualization that can be easily shared with leadership and stakeholders. Another important tool in MDRO surveillance is the antibiogram. Antibiograms help guide decisions on antibiotic treatment, but they are useful tools for detecting and monitoring trends in resistance. The antibiogram is an overall profile of antibiotic susceptibility testing results for a specific microorganism to different drugs. Looking at the table above, we can see that 1,272 isolates tested positive for E. coli, and 99% of them were susceptible to meropenem. Next, we'll look at strategies designed to prevent and contain the spread of MDROs. The CDC's interim guidance for public health strategies to prevent the spread of novel or targeted multidrug-resistant organisms describe 4 strategies that should be included in MDRO prevention plans, the first one being providing education. Well-directed education can increase healthcare personnel and facility administration engagement and adherence to recommended interventions. The second strategy is improving IPC practices. Adherence to good IPC practices is predicted to limit transmission of novel and targeted MDROs. The third is detecting colonized individuals. As mentioned previously, colonized individuals can be a source of transmission to others, particularly when their colonization status is unknown. Combining colonization screening with good adherence to core IPC practices will have a larger impact on limiting MDRO transmission than either of these strategies alone. And finally, facilitating communication. Communication between healthcare facilities and public health is critical. One example of increasing communication between healthcare facilities is the interfacility infection control patient transfer form, which assists in fostering communication during transitions of care. Basic data elements on the transfer form include patient demographics, facility contact information for the receiving and transfer facility, in addition to the infection and colonization status of several concerning MDROs, which include Candida auris, MDR Acinetobacter, and Pseudomonas aeruginosa. This helps to provide situational awareness of MDRO epidemiology and ensures appropriate containment measures are in place at the receiving facility to prevent further spread. CDC also has interim guidance for public health response to contain novel or targeted MDROs. The goals of containment are 1. Identifying affected patients, 2. Ensuring appropriate control measures are promptly implemented, 3. Determining if transmission within a healthcare facility and dissemination to other facilities are occurring, 4. Characterize organisms or mechanisms that have not been detected before to guide further response actions in patient management, and finally, coordinate response with ongoing prevention activities in the region. Most importantly, facilities should have a robust infection control policy with detailed instructions for IPC practices that limit the spread of MDROs. The following webinars will dive deeper into these core IPC strategies, but today we will take just a few minutes to provide a high-level overview of proper hand hygiene, transmission-based precautions, including enhanced barrier precautions, environmental cleaning and disinfection, including sink hygiene, and antimicrobial stewardship programs. So let's begin with hand hygiene. Healthcare personnel are required to perform hand hygiene in accordance with CDC recommendations. This means that the preferred method for proper hand hygiene is to use alcohol-based hand sanitizers for most clinical situations, as well as establishing and maintaining good hand hygiene observations by auditing and providing feedback to staff on their performance. This is essential to improving adherence to one of the most basic and effective means of infection prevention and control. What is a hand hygiene audit? A hand hygiene audit is a systematic review and evaluation of hand hygiene practices within a workplace or healthcare setting. There are several different types of hand hygiene audits, including the baseline audit, which assesses the current status of hand hygiene practices in a facility, providing a baseline for comparison with future audits. Follow-up audits, which are conducted after interventions or new procedures are implemented to assess their effectiveness. Routine audits, which are conducted regularly to ensure ongoing compliance with hand hygiene standards. And targeted audits, which focus on areas or departments identified at high risk or requiring improvement. There are also several different methods that can be used to perform an audit, some of which include the direct observation. This is the most common method, where auditors directly observe and record the hand hygiene practices of staff. Anonymous reporting, where staff members anonymously report their and their peers' hand hygiene compliance. Self-assessment, where staff members self-report their hand hygiene practices. Patient feedback, where feedback from patients regarding staff hand hygiene practices can be used as part of the audit. And electronic monitoring systems. These automated systems track hand hygiene compliance without the need for direct observation. Healthcare personnel should also be ready to implement standard and transmission-based precautions, or TBP, the two tiers of CDC recommended precautions to prevent transmission of infectious agents. Standard precautions are used in all settings and with all patients, not just those who are considered high risk. Standard precautions are based on an assessment of risk to protect healthcare providers from contamination and prevent the spread of infection between individuals, such as patient to patient, staff to patient, or vice versa, or through shared equipment. Standard precautions include the following practices: performing hand hygiene, using personal protective equipment whenever there is an expectation of possible exposure to infectious material, such as blood or bodily fluid, secretions, or excretions, following respiratory hygiene and cough etiquette, ensuring appropriate patient placement, properly handling cleaning and disinfecting equipment, instruments, and devices, cleaning and disinfecting the environment appropriately, handling textiles and laundry carefully, handling needles and sharps safely, and following safe injection practices. Contact precautions are a type of transmission-based precaution, which are used in addition to standard precautions for patients with known or suspected infections that can be spread via direct or indirect contact. This requires the use of gown and gloves to be worn every time someone enters a patient's room. Ideally, patients on contact precautions should be placed in a private room and restricted to their room except for medically necessary care. The duration of contact precautions is intended to be used for a limited time to prevent transmission while someone is infectious. Enhanced barrier precautions, or EBP, are a modified version of contact precautions designed to reduce transmission of MDROs in nursing homes. EBP requires the use of gown and gloves during high contact care activities. These activities include dressing, bathing or showering, transferring, providing hygiene, changing linens, changing briefs or assisting with toileting, device care or use, and wound care. These high contact resident care activities are often bundled together as part of morning or evening care and performed in the resident's room. Healthcare personnel should implement EBP or residents with wounds or indwelling devices, as these residents are considered to be at increased risk for MDRO acquisition. Additionally, EBP should be used for any resident with an active infection, known to be colonized with or have a history of an MDRO. Unlike contact precautions, EBP does not require room restriction or placement in a private room. However, EBP should be maintained for the duration of the resident's stay in the facility. Finally, it is important to remember that EBP should be used in addition to other infection prevention and control measures such as hand hygiene and environmental cleaning. Now, when is EBP not recommended? It is not recommended for residents infected or colonized with an MDRO who also have acute diarrhea, draining wounds or other sites of secretions or excretions that are unable to be covered or contained, or have a condition where contact precautions are recommended, such as C. diff, norovirus, or scabies. Additionally, contact precautions should be implemented for a limited time on units or in facilities during an investigation of a suspected or confirmed MDRO outbreak. For environmental cleaning practices, you must also think about disinfection, as both are critical steps in reducing and preventing transmission of MDROs. This should include using Environmental Protection Agency or EPA approved cleaning and disinfection products, or a product that does both at once for at least daily cleaning and disinfection of high touch surfaces, such as those pictured on the slides, including door handles, light switches, bedpans, and toilet handholds. There should also be consistent cleaning and disinfecting of non-disposable and non-dedicated equipment after each use, including but not limited to vital sign machines, glucometers, portable radiology equipment, and transfer and shower equipment. Along with knowing the right products to use, staff with cleaning responsibilities should know and understand the correct contact time for these products. Contact time is the amount of time a disinfectant must remain wet on a surface to be effective. Many products indicate various contact times based on the germs it is targeted to kill. In most healthcare settings, it is often appropriate to use the longest contact time listed to ensure the disinfection of a wide variety of germs found in healthcare facilities. It's also important to note that Candida auris requires specific cleaning and disinfection products. List P has EPA products with claims against C. auris and are the preferred agents for the disinfection. If a List P agent isn't available to you, then facilities could use a product from List K for registered antimicrobial products effective against C. diff spores, which would also be appropriate for the disinfection of C. auris. You may want to strongly consider using these disinfectants even if you have yet to identify an individual with C. auris. This may be particularly important if multiple cases of Candida auris have been identified in facilities that you frequently share residents with. Now, I would like to speak briefly on sink hygiene. Sinks and drains within healthcare facilities can become contaminated with MDROs. Thus, it is very important for your facility to remember the splash zone for sinks and drains, which is considered 3 feet on all sides. Healthcare personnel should not place items such as patient care equipment or medicines within the splash zones. In addition, all facilities are encouraged to develop a water management program to limit Legionella and other opportunistic pathogens from growing and spreading in their facilities. Finally, implementing antibiotic stewardship programs are important to optimize the use of antibiotics by improving antibiotic prescribing. This can be done by dedicating resources to antibiotic stewardship programs, which includes appointing a leader or co-leaders, such as a physician or pharmacist, to be responsible for program management and outcomes, implementing interventions, and using the data from the antibiotic resistance tracking spreadsheets discussed earlier to monitor the impact of these interventions, and educating healthcare personnel and patients about antibiotic resistance and optimal prescribing. Next, we're going to discuss public health global efforts and initiatives. In May 2016, the WHO developed a global action plan to address the growing antibiotic resistant crisis. The Global Action Plan provides a framework of actions for countries to take within 5 to 10 years to combat antibiotic resistance. The 5 objectives outlined in the Global Action Plan are to improve awareness and understanding of antimicrobial resistance, strengthen knowledge through surveillance and research, reduce the incidence of infection, optimize the use of antimicrobial agents, and ensure sustainable investment in countering antimicrobial resistance. This plan will ensure continuity of successful treatments and the prevention of infectious diseases. There are also international collaborations and partnerships that address the emerging AR global health threat. For example, the Global Antimicrobial Resistance and U.S. Surveillance System, or GLASS, is the first known global collaborative effort to standardize AMR surveillance. GLASS supports the second objective of the WHO Global Action Plan by strengthening knowledge through surveillance and research. Efforts are focused on low and middle income countries working to build capacity to develop and implement AMR surveillance. Additionally, the Joint Programming Initiative on Antimicrobial Resistance is a collaborative platform made up of the European Commission and 29 member countries representing 5 continents. The focus of this initiative includes stewardship efforts such as improving diagnostics, therapeutic regimens, and surveillance. Earlier in the presentation, we talked about the Antimicrobial Resistance Laboratory Network. CDC also has a global ARLN that supports countries outside of the US by improving detection of AR threats, identifying risk factors, aiding in response activities, and informing global prevention strategies across healthcare and community and the environment. In 2022, more than 24 partners have implemented collaborations in more than 42 countries to launch the Global ARLN initiative tackling threats like Candida auris, carbapenema-resistant Enterobacterales, Neisseria gonorrhea, and Streptococcus pneumoniae. The last topic we're going to discuss today are steps being taken to guide future MDRO prevention and containment responses. Antimicrobial resistance requires an interdisciplinary solution. In 2020, the U.S. Department of Health and Human Services developed the National Action Plan to strengthen and expand the U.S. government's response to AR threats. The plan takes a One Health approach, meaning it will involve experts in human, animal, environmental health, and other relevant disciplines to learn how MDROs spread among these domains. The 5 goals of the plan are to slow the emergence of resistance bacteria and prevent the spread of resistant infections, strengthen national One Health surveillance efforts, advance development and use of rapid and innovative diagnostic tests, accelerate basic and applied research and development for new antibiotics, antifungals, other therapeutics, and vaccines, and improve international capacity for surveillance, AR prevention and control, and drug research and development. This One Health approach could potentially achieve the best health outcomes for people, animals, and plants in our shared environment. The next couple of slides talk about policy initiatives that align with the One Health approach. First, the Centers for Medicare and Medicaid Services, or CMS, works to prevent the spread of antibiotic resistance through its regulations of healthcare facilities. CMS requires healthcare facilities to have a dedicated infection preventionist that ensures the development and implementation of policies that govern the identification, reporting, investigation, and control of communicable diseases among patients, residents, and healthcare personnel. Next, in June 2021, the U.S. Food and Drug Administration, also known as the FDA, finalized Regulation Number 263, which requires a veterinary prescription for all animal antibiotics. This means antibiotics will have to be purchased from a licensed pharmacy, and they will no longer be available over the counter. Additionally, feed stores will have to be licensed to accept prescriptions. This regulation aims to limit the emerging AR threat among animals while ensuring the availability of safe and effective antibiotics for use in animals. And historically, regulatory efforts have been directed towards humans and animals, but with the growing understanding of the importance of a One Health approach to AR, it is just as important to focus efforts on environmental factors. Wastewater surveillance, or WWS, is a rapid technique that provides essential information about an individual's health. This is done through the detection of urinary and fecal markers within a given wastewater runoff area. The concept of WWS relies on the observation that wastewater is one of the primary pathways for introducing antimicrobials and resistant microbes into the environment. Testing wastewater for the presence and diversity of antibiotic-resistant genes can reveal where and to what degree resistant bacteria are introduced into the environment. From a surveillance point of view, municipal sewage can provide data that supports AR monitoring as it includes pathogens from the entire population of a community. A variety of data points can be determined, such as colonization status and infection stages, which include pre-symptomatic, symptomatic, and post-symptomatic. Additionally, specimen type and location can also be assessed. Samples may be collected from households, hospitals, and nursing homes and may include specimens from feces, urine, nasal mucus, skin, and sputum. Wastewater surveillance can provide an opportunity for real-time monitoring or act as an early prediction tool for future outbreaks, inform public health interventions, and track the effectiveness of these interventions over time. So as we have discussed today, antimicrobial resistance is one of the greatest threats we face. It will require a coordinated and ambitious action plan to avert a potentially disastrous global crisis. The world is already feeling the economic and health consequences as crucial medicines become ineffective without harmonized and immediate action. The world is heading towards a post-antibiotic era where future generations will face the impacts of uncontrolled antimicrobial resistance, and common infections could kill once again. Initiating a global One Health approach could provide a solution and ensure a sustainable future for all. This includes prioritizing national action plans to scale up financing and capacity building efforts, building stronger regulatory systems for responsible and prudent use of antimicrobials, urgently phasing out the use of critically important antimicrobials as growth promoters in agriculture, and investing in research and development for new technologies to combat antimicrobial resistance. Thank you for all your time and attention this afternoon. My contact information is listed here on the slide, and I look forward to working with you all in the future.
All right, thank you so much, Kate. We really enjoyed that presentation. It's very informative, very timely. I think there's a lot of good conversation going on in the chat. If you guys haven't looked at it around, I think one of the apps that you presented earlier. So please take a look in the chat box. We are right at time, so unfortunately we're not going to get to any questions, but thank you to Melanie Roderick, who has been answering some of those in the chat box. But thank you everyone for attending. A lot of thumbs up, a lot of hand claps, and a wonderful presentation. So everyone be on the lookout for information about our upcoming MDRO webinar series, and we look forward to seeing you next time. Thank you.